hypertension in adult. So that's why it looks high, because it occurs at certain age of population. Asthma is different. One of the disease that the prevalence is or incident is started from the very young age until the very old age. So we can say that asthma, because of the spectrum of the spectrum of the age of the children and adult, involving the children and adult. So actually, it is one of the most common chronic illness worldwide. If you include children and adult. Right? Though at the moment in adult, the highest prevalence of disease is diabetes, 10%. And the prevalence are increasing in many countries, actually not increasing stable, especially but in children, the prevalence are increasing. And it is a major cause of school and work absence. What definition of asthma? Asthma is a heterogeneous condition. You know what heterogeneous condition or not? Heterogeneous conditions means that there are many causes, many disease of that produce the same presentation. So like hypertension is the end outcome is hypertension, but there are many disease can cause hypertension. So they're heterogeneous. If one disease causes one condition, one condition, then we call it homogeneous. So asthma is one of those like hypertension, which is heterogeneous. It's heterogeneous condition characterized by paroxysmal or persistent symptoms such as dyspnea, chest tightness, wheezing, and cough against the background of chronic persistent inflammation. So the key here is chronic persistent inflammation. They result in the symptoms of dyspnea, chest tightness, wheezing, and cough. And because of this problem, it will cause structural changes associated with airflow limitation and airway hyperresponsiveness. This is the definition of asthma. And asthma is worldwide. It's a low difference prevalence in different countries. In developed countries, it can go until 10% to 15%. In Malaysia, roughly 5 to 6%. Even in Malaysia, there are differences in terms of urban and within countryside. The higher in the urban region can go until 5 to 8%, 9%. In urban countryside, just 1 to 2%. And asthma prevalence is almost all countries in the world, with different countries, different prevalence, and then still asthma can cause death. Remember, asthma still can cause death, mortality. And in our country, roughly, we estimated in a Z study, the children with symptom of asthma and allergy is around 16.4%, but not asthma alone, asthma and allergy. Whereas in different age also they have increasing from 10% in 1998. Even that, still we consider that asthma still underdiagnosed. In National Health Survey 2006, look into the prevalence of asthma in Malaysia. Roughly in children, asthma in children in Malaysia, roughly the male is higher than female. And then the data is shown that asthma mainly diagnosed at the age of 10 to 14, 18 years old. But the problem is that this is the age of where there are the rising number of asthmatic patients. Here, 0 to 4. Actually, this is old data, 14 years ago. Now we believe this bit more different, and we believe that 0 to 4 is quite high. So what factors influence asthma development and expression? So there are, in many other diseases, asthma is an interaction between host factor and environmental factors. in many, just like another disease. Host factors include genetic, atopy, airway hyperresponsiveness, gender, and obesity. Whereas environmental factors include indoor allergens, outdoor allergens, occupational sensitizers, tobacco smoke, air pollution, respiratory infection, and diet. So the interaction between these two. So to summarize, how the interaction are is that genetic factor and environmental factor and age as in between, the result in all these factors like genetic factors influence our cytokine response, and environment factors which include allergen, pollution, infection, microbe, and stress. And in the middle is age, and this all result, the outcome is that the alter innate and adaptive immune response. And this, when there are triggers, what the triggers are, usually like lower respiratory tract infection due to virus, RSV virus, adenovirus, chlamydia virus, mycoplasma virus, result in symptoms. This what we call symptoms. The symptom is a persistent wheeze and asthma. So looking back, when we summarize the flow chart, the key is the inflammation. Inflammation process. Inflammation process. This is the primary cause. Allergens, sensitizers, virus, air pollutants result. This is the background problem. Inflammation. The inflammation will result in airway hyperresponsiveness. Inflammation result in airway hyperresponsiveness, and this heavy hyperresponsiveness because of the trigger factors like allergen, exercise, cold air, sulfur dioxide, particulates, symptoms. So when a patient come to see you, they come you with symptoms, cough, wheezing, chest dyspnea, and so on. So they come with symptoms. This is what the patient complain of. So always remember that the symptoms tell you that there are some problems that happen to your patient, the underlying problem which you have to solve the symptoms. So the chief complaint consists mainly symptoms. This is why the patient come. So understood that's why you all learn physiology, pathology, biochemistry during your preclinical year to understand all this, because this involve we call it pathophysiology. Involve pathology, physiology, biochemical, and so on. And when you come to us to learn clinical, you come to us to learn that patient come with symptoms, and then with symptoms you try to find out what's happened, what is the cause of these symptoms. So this is a bit more complex. Involves cellular and airway wall. You see the cell that involved mast cells, neutrophil, eosinophils, Th2 cell, and then the macrophage cell, and then this is cell wall, which involve the vessels, mucous glands, and epithelial cells, nerve, end of the nerve. Because it's a complex interactions between the cells and the structure, the airway structure. It's more complex. It's more complex diagram to show you, just to show you, to illustrate to you all the complexity of the airway hyperresponsiveness. Just tell you, that's all. It involves so many cells and structure in the airway wall, and also the cytokines, the chemical cytokines, immunoglobulin, antibodies, and interleukin. It's just to illustrate to you the complexity. And even you look, because we know that asthma mainly because of the airway diameter becomes smaller, and you see so many factors that affect the airway diameters. So many factors. And this is even there are some substance that we still not understood, like substance P. Just to tell you that the complexity of the control of the epidimeter. But what you see, what you saw on your patient is this: bronchospasm, asthma exudation, mucous secretions, airway hyperresponsiveness, and structure changes. This is what you see in your patients. Though they are involved the inflammatory cells, structure cells, mediator, and but then what you saw is the effects of the effects from this interaction between all the mediators and then from this come the symptoms. The symptom is all symptom respiratory distress. The effects, this the effects, and then the symptoms come after this. So this is the airway of the patient who are having asthma. You can see the lot of infiltration, right, from the cell, especially inflammatory cell, and then you can also saw the airway which is blocked by the exudates and cell that been shift out. So you can see basically discrimination of epithelial cells, mucus plug, and then edema of the airway wall, and then the other thing is the bronchospasm. Result for the smooth muscle hypertrophy and contraction is the main thing. Then result is that the airway become small compared to this normal patient, the airway, and this asthmatic patient. You can see with very small airway, very increased, the resistance become higher, and then very little air can go in and go out, result in not inadequate of oxygen come in, inadequate of carbon dioxide come out, and the patient will become hypoxic, clinically hypoxic. See this another diagram. You can see this normal airway, nice looking lumen, very clean lumens, and then there is the airway of asthmatic patient. You can see small lumens, edema of the airway walls, thick mucous membranes, and this is the pathology of the asthma. And then this very important diagram. If you can't remember anything else, the one that I have told you earlier, or informed you earlier, if you can remember this, I think is enough already. Here you can look, you can see what is the wall of the pathology of the effect of the asthma, or all the mediators, the cells to the wall of the airway. And this is the clinical presentation to understand this simple diagram. So basically there is a chronic inflammation of the disease, and then during over the time there is an episode of acute inflammation. So usually patient will be symptomatic here. During the acute inflammation, they come with tachypnea, difficulty in breathing, wheeze. This will come during this period. And then over the time, there are also structure changes. Structure changes over the time. But basically, the key of asthmatic disease is chronic inflammation. You remember this, chronic inflammation. So this is one of the airway of the child who died because asthmatic attack. You can see that when they cut longitudinally the airway, you can see the airway opened up. There is a lot of sedimenters. Pardon? Yes? Yeah. You can see a lot of edema, swollen of the airway. Imagine if you try to close this airway, you try to close it back. you can see, you can imagine the blockage of the airway so much that in this case, perhaps there's no air can come in and come out. The result is the patient having severe hypoxia, and then because of that, because severe hypoxia, patient die. Yes, you can imagine that. This is those cases who was severe acute exacerbation of bronchial asthma. So little bit asthma in children. The main thing, we are not fully understood about the asthma in children. We yet don't understood very well when the asthma initiation. There are argument of when the age we can call child having asthma, and then we believe that different cytokine involved, interleukin-4, and persistent asthma. When the child who have acute asthma diagnosed, started to have asthma, then after that become persistent asthma. So we believe that different interleukin involved, interleukin 13. So there are many things that are unanswered about children, asthmatic in children. So when it started, well, do we start it with clinical first or with airway changes? How is the asthma in infant, toddler, preschool, school and adolescents? How similar are they? How different are they? Are they same with adult asthma? What the link between the childhood asthma and adult asthma? Are all wheezing called asthmatic? And then many of the study of treatment of asthma is in adult. Is it applicable in children or not? Can we use the adult study to use it, and then to use the study how to plan for childhood asthma management? We are not sure about that. So what few things we understood. We understood that 20 to 30% of children wheeze at the age of 1 year. It means that at your, let's say you, how many you all now? Total number. How many you all? You five. You, how many you all?
136.
136. 30% of you, how many? 50.
40.
So 40 of you, at least 40 of you have episode of wheezing at the age of 1 year. And then 50 70 of you, 60 of you have wheezing episode, at least one wheezing episode by the age of 6 years. It's so common. So how many of you asthma? So when we can say that you are asthmatic, something that we still are unable to answer completely. But what we understand is that the younger the child, the less likely they are wheeze due to asthma. You may wheeze, perhaps you're not asthmatic. And the younger the child, you are wheezing because viral induced, whether the asthma, and then the older you are, you're wheezing associated with atopy. And then perhaps this is the asthmatic case. So how do wheeze look like? So we're looking about the wheezing, the symptoms, and then the age. You can divide that. There's some children who wheeze here early in the life, even 60% of them wheeze at this early of the life, but over the time, 3 years and above, the wheezing stop. And we call this transient early wheezer. But there are those who wheeze early of their life, then they continuously wheezing until they become older. We call it persistent wheezer. And there are those who wheezing at 3 years, who are not wheezing at the early of their life, but wheezing at the age of 3 years and above. We call it late onset wheezer. So there is a different type of wheezing in children. But what we believe is that the majority of them, which is here, transient early wheezer, they are not asthmatic despite they having recurrent wheezer. But those with persistent wheezer or late onset wheezer, this is the one perhaps as asthmatic. So how to go about in asthma? As usual, history. Very important to take a very clear, with clarity history. History had to go because the chief complaint mainly shortness of breath and wheeze. So the wheezing, you're asking the history of wheezing, the cough, shortness of breath. Look for the specific triggers that cause the wheezing, cough, and shortness of breath. Look also their sleeping patterns. If they awaken at night, got night cough, they have sleep apnea, and then ask them if they have any exacerbation in the past years. And then very important to not to forget about the nasal symptoms, especially the sneezings, itchiness of the nose. And then certain, what specific trigger you're talking about? Look, there's smoke, pets, humidity, mold and dampness, respiratory infection, cold air exposure, exercise activity, cough, and laughing, crying. All these result in shortness of breath or wheezing or not. There are specific questions you ask, let's say for the 2 years old and less, ask about nausea, breathing, vomiting associated with cough, any retractions, difficulty in breathing, any grunting sound, poor sucking, and changes in respiratory rate. For the more than 2 years old, perhaps you should ask about the shortness of breath, fatigue, fatigue, decreased playing compared to peer group, complain about not feeding well, poor school performance and school absence, reduced frequency or intensity of physical activity, avoidance of other activity. Then look what trigger. Is there any sports exercise that trigger the shortness of breath? And adolescent, don't forget about the smoking. And don't forget about atopinas. Any family history of asthma, especially the parent, any history of eczema, allergic rhinitis, dermatitis in the child and also in the family, close family members, allergic rhinitis, normally panggil resedong, and any allergic to food. Ask about that. Other thing you have to ask, prematurity, maternal smoking, tobacco exposure, any exposure to tobacco smoke. This, if they were sent to nursery, and the caregiver family condition also. Caregiver, who's the caregiver is environment, especially they stay near to the factory, near to the main road, and so on. Physical examination wise, please note that normal physical signs do not exclude asthma. At many times, patients come to see you after, if they don't come not with acute exacerbation, when you ask you find mainly sometimes you found the physical examination is normal. Unless patient come with you during acute exacerbation or symptom, then you can find something to your physical examination like bronchi and so on. But many times you found out it's normal. But look for dysmorphism, clubbing the chest deformity, and failure to thrive, hypotonia, because all this perhaps suggests you're not dealing with asthma. And look for atopic eczema, dry skin, allergic shiner, conjunctivitis, allergic crest, turbinate hypertrophy. And this is one of the typical finding you found in patient with chronic asthma. Siapa tahu apa benda ni? Anybody? Yeah. This is the factors carry atom. But you can see some depression of the lateral side of chest wall where the insertion of the diaphragm, they call Harrison sulcus. This one, anybody ngerti apa ni? This is the hidung, dalam hidung. You see the turbinate is shiny, and you can see the this one. You can see the allergic shiner. This dipanggil apa tu? Allergic crest. And then conjunctivitis. So this is all, you see the eyes, the lower part of the lower lips look dark and dark color and dark cycle color. All this sign of allergic rhinitis, a sign of atopinas. Investigation wise, sometimes not necessary. Sometimes if patient comes, you know already the patient is acute exacerbation of bronchial asthma for your diagnosis. And then from your diagnosis also is there is previous history of asthma, previous history of admission. Perhaps you don't need to do any investigation. However, in very young age, maybe you need to do the chest X-ray. Okay, you may do the peak flow or spirometry to look for post treatment response type of the a lung problem, and also you look if there is the response to the bronchodilator. But mind you, in children, certain age, that less than 4 to 5 years, usually they cannot do this lung function test. They not cooperate. Sometimes you ask for skin prick tests, those very atopy child, or sometimes you can ask RAS test. You mean you take the blood, look for the level of the antibody to certain antigen, and certain place, if you have adequate facility, you can ask nitrous oxide levels, breast condensate, eosinophil count, level, eosinophils level in sputum, but mainly we do it in the research center. And certain place, if you have sleep pulmonary lab, you can do methacholine, histamine, mannitol, hypertonic saline test, but mainly is in adult. Occasionally, we do it in children. So lung function test, the peak flow, what it tell you is that you see you compare between how you interpret. You have to know the patient best expected value, and 6 to 80% moderate severe, 60% considered severe. So you find the percentage for the patient best expected normal value of the patient. We have national value. We have it, national value, and reversibility. I mean that contraction of the airway. How if you give patient nebulizer or bronchodilator, you do the pre pubertal capacity, then you put post pubertal capacity. Sorry, pre-peak flow, then post peak flow. Then you look into the difference. 20% difference, that is significant. Yeah. This is if you do the peak flow test. In spirometry, you do for FEV1, do for 12% difference. Okay, spirometry, perhaps you just know about it, that's all. This is force respiratory volume in 1 second. But peak flow, try to understand it. Peak flow. I think adult use a lot of peak flow. Anybody give you lecture about adult asthma? Ada tak lecture adult asthma? Ada ke tak ada?
This year tak ada lagi.
Tak ada lagi because they use a lot of this peak flow. Pediatrics we don't use much because we found out many our patient not cooperative. But you have to understand to recognize the value when you do it. Satu, we look for the peak flow to see the value at that time when you do during at that time, especially when patient got acute exacerbation. And then the other ones you look for reversibility pre and post. After pre-nebulizer and pre-bronchodilator and post-bronchodilator. Okay, what differential diagnosis? There are many differential diagnoses of wheezing. This you can see the list here. Many from the upper airway, large airway, small airway, and other causes. So about the triggers, remember the triggers. Triggers mean that the trigger that can cause acute exacerbation or making your asthma poorly controlled. Look for edemal dander, dust mite, pollen fungi. Other there is exercise, viral infection, smoke, changes in temperature, strong emotional expression, aerosol chemical interrupt. These are common indoor allergen, dust mite, cat, cockroach, fungi, and damn fungus. Tahu ni apa ni? Is a house dust mite. Cats and dogs. Let me see how intimate they are. Outdoor pollutions, particulate sulfur dioxide, ozone, nitrous dioxide, vehicle exhaust, open burning factories can result in asthma exacerbation and decrease in lung functions. The other thing is exercise-induced asthma. We recognize trigger for asthma exacerbation. Remember this, because exercise. But remember, exercise intolerance may suggest inadequate asthma control, which require further evaluation and treatment and optimization. So, but really always remember that exercise and playing is part of the children's life. So you have to know how much asthma affect them, and this playing also can trigger their having asthmatic attack. So always remember asthma, eczema, allergic rhinitis, how they affected each other, and look into the family history and increase, because this is sometimes in one family they can have atopy history. Somebody got eczema, somebody having asthma, somebody got allergic rhinitis, or sometimes one person having this all. And this all, especially eczema, allergic rhinitis, can increase severity in asthma. So remember again this diagram. I go through again. The key is complete chronic inflammations, and then at a certain time the acute inflammation result in the acute exacerbation and the structural changes. So how you manage asthma? Whenever you to manage something, you should have a goal. What the goal of asthma management? Maintenance of normal activities, including ability to exercise. Remember, we put it as number one, ability to exercise. No absence from school. No visiting to emergency and any hospitalization due to asthma exacerbation. No mortality and no side effects of medication. This is a goal asthma. So asthma management include non-pharmacology and pharmacology. And then the first thing, try to avoid triggers and pollutants. And then remember, tobacco smoke is a problem. Many cases we have difficulty to control the asthma because of tobacco smoke. Then by right, both parents should not be a smoker by right, but then it's much easier said than done. Many of the parents, despite they know that the child is asthmatic, they still smoke. This level of smoking cessation. Common indoor allergens, the control measures from the house dust mite, pests, cockroach, and moles, and then allergens, pollens, and then how to environment air pollutant, avoid that. So background asthma, you have to understand the background asthma before you start for the newly diagnosed asthma. And then to decide, is it a intermittent or persistent? Because persistent, it prevents intermittent reliever. And then after you start the treatment, you go to the control. Uncontrolled controls, and in addition to decide the control, daytime controls, limitation activity, nocturnal symptoms. So you look at the 5 things: daytimes, activity, malam, night. If the child need to use bronchodilator, and if you can do lung function test, is a bonus, it's a plus point. Many children we can't do. You can do at the peak flow or spirometry and look for any acute exacerbation. And this is the parameters: control, partially control, uncontrolled. Parameters is for the control, no daytime symptoms, no symptoms, and then no you need only reliever, or at least twice a week, less reliever. If you have none of this, you're good control. If you have 1 or 2 of these, 1 or 2, you are partly controlled. If you have 3 or more, you are poorly controlled. And then this is the medication according to the where to go in. If it's severe, the more severe, the more higher the medication you're going to use. And then when you manage the patient, when you look, you follow up them. If control, you wind down the medication, partly control, you may wind down or you may maintain it. Uncontrolled, you step up medication and you treat the exacerbation. There are comorbidities is asthma, remember, allergic rhinitis, obesity, and its complication and reflux. I remember obesity and asthma. Obesity is a disorder. Remember that. Don't take obesity as a granted, as is nothing as nothing. Obesity patients have a persistent mild chronic inflammation. Their CRP can be a bit higher than normal in the obesity. So just remember, obesity is basically is not a norm. So all asthmatic child who are obese need to lose weight, need to dietary modification and proper exercise, because one reason difficult to control asthma is obesity. Okay. Now we go a little bit about the drug. The drug, medication in asthma, we divide. One is reliever. Reliever is the one that we use immediately when the patient having symptoms or acute exacerbation. Mainly is beta-2 agonist. Sometimes they're anticholinergic. The beta-2 agonist can be salbutamol, tuberculin, or anticholinergic ipatoprene bromide. And then usually they are rapid onset, short acting, but the side effect can be tachycardia, tremor, and sweating, and taking when patient having symptoms when needed. Remember that relievers when needed. Example of reliever is the beta-2 agonist. This is the powder form. Either metadose inhaler or dry powder. In metadose inhaler, you see the metadose inhaler. This there are many types of powder. Small powder form. This tubular, this acular, and this I can't remember this anymore. Nama dah tak pakai this one. Preventer is what we use to prevent asthmatic attack, prevent and to control the symptoms. And preventer, you use it frequent, mainly daily. Best is used daily until you able to control the asthma, and then you stop it. The mainly is inhaled corticosteroid. It will be fluticasone, budesonide, cyclosporine, or it can be a montelukast, a leukotriene receptor antagonist, or it can be a combination of ICS, inhaled corticosteroid, and long-acting beta-2 agonists, which is serotype, a combination of fluticasone and salmeterol, or Symbicort, combination of budesonide and formoterol. And then remember, inhaled corticosteroid is safe as long as the prescribed dose is within the recommended range. Because remember that corticosteroid has side effect if used overdose and very prolonged use. To the preventer, you can see the MDI also, metadose inhaler, and then this is the fluticasone, this is budesonide, this is cyclosporine. And then the other one is combination therapy, which combine the long-acting beta-2 agonist and the inhaled corticosteroid. The other one is serotype, the fluticasone. This is the dry powder. This is acuheller, tubular, can't remember the name. This one. Easyhaler. This is easyhaler. So it's still acuheller. They call combination therapy. And so this is Symbicort, is use a dry powder combination therapy. The oral preventer mainly montelukast, can be 10 milligram, 5 milligram, or 4 milligram granules where you pour inside the milk, so the child can drink. So what the role of ICS? ICS reduce the asthma symptom. It reduced the use of reliever medication. It reduced the urgent care visits and but ICS didn't change the natural cause of the disease and the outcome of the lung function at the endpoint. But the most important is to control the symptoms. So in children, remember that we promote even must be given, medication must be given if especially in small children If you use MDI, you have to use the inhaler device. For the HR is 0 to 10, you have to use meter dose inhaler plus spacer face mask. This face mask, spacer face mask. So this is all. You must you ask them to use this, because if not, a lot of medication won't go into the lung, and then you're going to waste a lot of medication, and a lot of medication will go into the mouth, and then it go to the system. But for the age more than 6 years, yes, then they use a better dose inhaler with face mask, or better dose inhaler with mouthpiece, or they can use dry inhaler as powder base. So when you use this mask, or we call it wall holding chamber, this mask is increased lower airway drug deposition up to 25 to 50%, decrease upper airway drug deposition, especially large particles. No need good coordination, tak perlu, you just masuk dalam and you just inhale. You don't need to coordinate between the punch, when you punch the meter dose inhaler and inhalation. No need coordination. And then you can treat acute exacerbation. That's the good thing. If the patient having acute exacerbation, you can use the chamber. Chamber to treat acute exacerbation. It's very cheap, just even cheaper than nebulizer, and even it was recommended for all age. So last few slides about asthmatic attack. So what asthmatic attack after acute exacerbation asthma? Is exacerbation of asthma? Exacerbation of asthma, asthmatic attack or acute asthma are episode of progressive increase in shortness of breath, cough, wheezing, and chest tightness for some or combination of these symptoms. It characterized by decreased expiratory airflow that were quantified by the measure of peak flow at FEV1. This definition. But you know already, when patient come with you sudden onset of difficulty in breathing, chest tightness, wheezing, hypoxic, you know the child having acute exacerbation. Remember that. So aim of treatment acute exacerbation to relieve obstruction and hypoxemia quickly as possible, and to plan the prevention for the future relapse. Symptom: wheezing, chest tightness, shortness of breath, cough, and mucus production. So very important when you manage patient with acute exacerbation, because many patients admitted to the hospital because of acute exacerbation. If they have background asthma with some symptoms, coughing at night, inability in playing, or they have daytime symptom, they are not admitted to the hospital. They can see you in the clinics. But if they have acute exacerbation, they will be admitted to the hospital. So very important when you manage this patient is your ability to assess the severity. It can be mild, moderate, or severe life-threatening. So what the parameter look at: breathlessness, talks in, ability to talk, alertness, respiratory rate, accessory muscle usage, SpO2, pulse rate, and peak flow if you can do. So the mild, they can walk, they can talk in full sentences, then they're little bit agitated, the respiratory rate can be slightly normal or slightly increased, not using any accessory muscle, wheeze presents, oxygen saturation is good. But for moderate, they they're breathless when talking. The infant also develop difficulty in feeding, thought inferences, agitated, increase in respiratory rate, using accessory muscle, wheezing present, and then saturation is still good, but roughly more than 92% to 95%, and then increase in pulse rate, tachycardia, and the peak flow start to become 60 to 80%. Severe one, breathless even they are at rest, infant or stop feeding, talking only in words, agitated easily, markedly increased respiratory rate, a lot of accessory muscle usage, wheezing, saturation is less than 92%. I mean, they are sinus, but they are increased in tachycardia and their peak flow is less than 60%. life-threatening, very dangerous. You see the drowsy already, you poor respiratory effort, they have paradoxical thoracic movement, you ascatic, nothing, you can listen, nothing you can listen, the no air movement at all, and then the bradysinus and bradycardia. So very important to recognize the severity. But during when you manage this patient, you must know the onset of symptoms, if they have any asthma medication before, any previous exhibition before, and any other important medical history. Management in acute exhibition, the first line still heal bronchodilator. You have to give many of the case need steroid, oral corticosteroid, systemic corticosteroid, and many of them also need oxygen. Basically how you manage for mild, moderate, and severe. Moderate and severe. The mild, you can nebulize or you can give MDI, and then but you give oral penicillin. And for the moderate, you nebulize, you can add epatropium bromide, and or you can see MDI. And then for the severe, even you can other options like IV corticosteroid, IV salbutamol, subcutaneous tubulin adrenaline, IV magnesium sulfate, and consider IV to ICU management. Okay. Any questions? Any questions?
I have a question.
Hmm.
How to differentiate asthma and hyperactive airway disorder?
Asthma is hyperactive airway disease. Asthma is one of the hyperactive airway disease. Hyperactive airway disease is consists so many very large. It's a condition. It's not diagnosis. Asthma is a diagnosis, and asthma, the airway is also hyperactive. Okay.
Okay, doctor. Thank you, doctor.
The presentation really the same, but history will tell you which are the causes of hyperactive airway disease. There are many causes of hyperactive airway disease. Prematurity also, the premature 1.1 800 gram child, they can have hyperactive airway when they are big children. They are not asthmatic, but they have hyperactive airway. Any other questions?
Doctor, for children less than 5 years old, do we diagnose them as asthma or not?
That's what?
Do we diagnose them as asthma or not? Because
for age
for less than 5 years old.
Can.
Okay.
Difficult to diagnose, but you can diagnose.
Okay.
Not impossible, but very difficult to diagnose. The younger you are, the more difficult to diagnose bronchial asthma. Any other questions?
Dato, my name is Farah. I would like to ask 2 questions. So my first question would be, can we still use the asthma predictive index currently? Second question would be, if we were asked to mention about the complete diagnosis, what are the elements that we should include in for asthma?
Element, what element? History lah. That I present just now.
Maksudnya kalau dia tanya complete diagnosis, kita kena mention like dia punya control sekali ke?
Tak. Control the diagnosis is acute exacerbation of bronchial asthma, mild, moderate, or severe. That's all. Is it a severe, moderate, acute exacerbation asthma, moderate, or mild only? Then, if satu lagi, diagnosis background. If you come to the clinic, bronchial asthma well controlled, bronchial asthma partial control, but diagnosis is just bronchial asthma. Well control, partial control is a description. It's not the diagnosis. Description. So the first question tadi apa?
Currently, can we still use API?
API is using if not in asthma patient. Patient who have not yet diagnosed asthma, you want to diagnose asthma. And then the asthma, you only use for if the patient having more than 3 bronchospasm more in a year. 3 episodes of bronchospasm or shortness of breath in 1 year. Or wheezing episode, 3 episodes of wheezing in a year. Then only use the API index. It's just the probability of you are having asthma or you're not having asthma. That's all. We don't use with patient asthma. If you diagnose patient asthma, you don't need to use that anymore.
Okay,
Any
thank
other
you,
question?
Dato, what is the target SpO2 for children? Is it different with adults?
Sama lah, that's why 93 and above. Any other question?
Dato, according to the PITS protocol for asthma control, we have the level of intermittent control. So for
Level of?
for the partially control,
Hmm.
we have 3 category, fully control, partial control and control. So let's say that after we already exclude all the, maksudnya dia dah compliant, dia punya teknik pun bagus, adakah kita patut step up the medication for those with partially control?
Fully control tak payah. Fully control you always went down. Partially control, kalau full control you have to go up. Kalau partially control, you have to decide which one the best. You want to maintain or you want to increase? Depend. Kalau patient is well control, you just went down, turun ke ubat dia. Kalau poorly control, you increase. Okay. Any other question? Cari dah? Okay. Okay. Nak berhenti ke tak? 23. Berhenti? Tak berhenti?
Okay.
Okay, okay.
Thank you, Dato.
Okay.
Thank you, Doctor.
Thank you, Dato.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Biasanya baca doa rumah. Boleh mendengar lecture, boleh minum-minum.
Thank you,
Kan?
Doctor. Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.